it's really very important that we look at the individual's perspective of what is recovery. And for many of my patients, it's despite having symptoms that are higher than a 3 on the brief psychiatric rating scale, it's that even though that's going on, I can still work or I can live up to my highest potential, even though these symptoms are present. So that's kind of what I see for the people in my practice, that the way that they look at recovery. And then the other thing is, how do you figure out what treatments are appropriate for an individual? So we have the authoritative model, which we've already sort of used for a long time in treatment. We sort of prioritize the doctor's knowledge over and above what the individual may want to contribute. So I've actually sat in on meetings with a psychiatrist and a resident and a patient where the psychiatrist says, how have you been doing over the past 3 months? And they say, fine. And the psychiatrist said, good, keep taking this medicine. And so there's a real perspective that I'm the expert and I'm going to tell you what to do. But with shared decision making, this is a model where this is much more collaborative, where the values and the desires of the individual in treatment are equally weighed along with the expertise of the prescriber, so that this comes together in a collaborative way. And what we know is that if you do shared decision making, you see often better treatment adherence, better adherence to the medication. You often see a better therapeutic relationship. And so we're really encouraging providers to use shared decision making. There are some issues that come up with it. People will say, well, that takes too long, that it's complicated, and, caregivers might have to be involved in the process, and that takes longer. And sometimes, patients don't want to have input. They say, you decide. So it takes a lot of effort to get people involved. But if we do that, the research consistently shows that there's a positive effect of shared decision making, even if it might be small. And even though it might take a little extra time at the beginning to really involve the person and understand their perspective, what we find is that over time, their treatment is easier to manage. And there's less people sort of on fire in the waiting room because we have this collaborative working relationship. We can sort of head things off at the pass. We know more about the individual. So I think it's really a valuable way to go. Do you have any thoughts, Dr. Rao?
I think this is actually a really nice thing to bring up in terms of how you get buy-in from patients about their own treatment. I experience this a lot working on an inpatient unit, because often the patients that I see, I'm seeing them for the first time, or maybe I've only seen them a couple of times. And how do you build rapport and trust with a patient who you've never met before and who's never met you before? And I think one way is this: to make it really clear to the patient, you're not trying to tell them what to do. What you're trying to do is give them the best options that you have available, the best knowledge that you have available, and then you're going to make the decision along with them about what's going to work well for their life.